classes, and again, just to review how you pick stuff. We kind of did this a little bit yesterday with our Mr. Taylor patient. So we're gonna do that, and then tomorrow we have a lab. I have with me the lab for tomorrow that has some math on it, so if you want to take it home and try some of the calculations we just did for practice, it doesn't even know like that. But we'll do that tomorrow as well. So again, when you're picking a mode for the boards, it doesn't make any darn difference which one you pick. You just have to be able to guarantee a minute ventilation, okay? Now, pressure control situations are always really important when you're thinking about somebody with chest trauma, flail chest, things like that. You know, in a volume control mode, the volume is set and therefore guaranteed, okay? Pressure control mode is the pressure that's set, and so tidal volume will vary. We've already discussed this, but it's here just to review. You're going to target your tidal volume if you're setting volume ventilation for 68 mLs per kilo. 6 to 8, not 68, let me say that again. 68 mLs for ventilating an elephant, woohoo! And then we have varying ranges for people who have bad lungs. So ARDS and COVID are 4 to 6. Asthma is 4 mLs per kilo. Now, you're going to hear from Kettering when you get there in your 5th semester that it's okay to use the range as wide as 5 to 10 because it makes the math nicer. Okay, so if you have somebody who's 65 kilos and multiply it by 10, that's 650. I have that bad boy, that's 325, I'm done. No more math. Okay, so Kettering is going to teach you that hack. Doctor was very specific that we want to use 68 because that's what they have told him to use on the board exam. Make sense? 100 years ago when I went, we were doing 10 to 15 mLs per kilo. So we were doing like big old monster tidal volumes. When you're picking initial settings, it's pretty safe to go with the lower side of the range and the lower side of the rate as long as you're guaranteeing the minute ventilation that you want, okay? If we're starting off at a minute ventilation less than 5, that's probably not gonna be good. So you need to consider that. And as you guys figured out yesterday, and Diego was the first one to point it out, without the proper flow, you're going to get a weird eye time. So you always need to, those 3 things are related. So tidal volume, flow, and eye time are all going to be related so far as how does the machine deliver that volume to your patient, okay? So calculation of tidal volume, you know how to do this already. We find our ideal body weight, and then we use our 6 to 8. You can use the smaller volume of the 2 if given the choice. That's usually safe. And you know how. So respiratory rate, like I said, one book says 12 to 20, one book says 10 to 20, I don't care. Something less than 20, okay? And more than 10, yours should be good. You want to use the lowest respiratory rate available, so you guys all picked 12 yesterday as a starting point, that was pretty good. And we're going to need to go up or down depending on how our ventilation status is. So if we have a respiratory acidosis, well, I'm going to go up on that tidal volume like we said over here. And then if that doesn't fix it, I have to go up on the rate. Okay, any questions about where to start off the rate? This is also on your cheat sheet, the back of which has your alarms. Okay?
So do you always just start off, because when we were doing the worksheet thing yesterday, I started off with just like randomly picked 18 because I was like, well, this guy's got a little bit of CO2 built up, like maybe I can pick a higher respiratory rate to blow that off a bit, but would you still start off with the lowest regardless and then work up?
So, no, your thought process is perfectly agreeable. That's exactly what we do. And in fact, on real people, that's what we do. And we may even start a real human at Loveless on a rate higher than 20. So again, the 20 is the cutoff for the board thing. You guys have all seen it. If you've been around the hospital, who did you see set less than 20? There's not very many people like that. Because we really are trying to blow down their CO2, we have to ventilate them quickly for that. Okay, and we can't take the tidal volume anymore because we're already maxed out at that 8 ml per kilo. Or in the cases of COVID, we're using that 4 to 6 range. That doesn't give you a whole lot. So if I need to increase minute ventilation and I'm maxed on my tidal volume, I have to use the rate. Okay, so no, that was a very good thought process. Okay?
But for the boards, you start off at the lowest and then work
Start off
up?
with the lower one, okay? Now the problem with the boards is you're gonna get 4 choices. 2 are going to be stupid, because 2 are not going to be in range, but 2 are going to be really juicy, and you're going to go back and forth on which one do I like better, and sometimes it's just a toss-up. It's whoever wrote that question and what they made for the key. Sometimes they both make perfectly good sense, and you're like, well, hey, I picked 12, you picked 14, what the hell? Well, just because they wanted 14. Sometimes it happens like that.
So again, it's just really a guessing.
Yes, and so you're trying to find the best of the worst, and I mean that sincerely, the best answer out of the 4 terrible choices. Because there's just so many dumb crap that the board exam does that we don't do on real people, you know? And actually, we had a meeting with our campus director, an associate campus director, and she said, well, you know you're not supposed to teach towards the boards. Like, we're not only teaching you to get past the board. I said, of course not. I said, I'm teaching you how to be an RT and to get a job and not kill people. But I also have to teach you how to pass the boards based on these stupid rules, or you would never do it. You would never get past the boards. And then you wasted 2 years and $80 gazillion, or however much the hell you're paying for school. I don't even know, but it's a lot. It's a lot. I know I don't get paid that much money. I wish I did. But you know, it's a company. So I don't pay attention to the business side of things. I just want my paycheck and I want you all to turn out good. I don't really care about anything else. So FiO2. The rule is very simply, if they're on room air to start with, you can use 40 to 60%. If it's an emergency, you get 100%, no matter what. Even if they have COPD, they still get 100%, okay, in the emergency situation. However, if it's a COPDer who had their knee done, and they're just recovering in PACU, I'm gonna wanna keep them between 20 and 32%. Does that make sense? Too much oxygen in our COPD friends will mess them up. So if it's not related to an emergency, okay, and Ray, I don't know if I gave your points back on your question yesterday, because I could see your point where you're going with it. If it had just said, if the question had just read, an intubated patient is already being sent to PACU for recovery, you would have known what to pick, right? It was the wording of it, I could see, it kind of was confusing. Anyhow, so emergencies are like CO poisoning, near drowning, a PaO2 of less than 40. If you run a gas on somebody and their PaO2 is really, really crappy, that's considered an emergency. Acute pulmonary edema, somebody who's coded, myocardial infarction, which is an MI, those guys all get a lot, okay? So that's the rules for the FiO2. Does anybody have any questions? We've talked about this before, but I wanted to kind of tuck it back in here just so we could review it. So PEEP can be anywhere between 2 and 6. You're going to see most of us in the hospital use 5 just because we're trying to get back to that normal physiologic PEEP. If we're going past 10, the boards consider that therapy. We're actually doing therapeutic PEEP. And you need to prove that somebody needs that much PEEP. So you're not just going to pull PEEP of 10 out of space, unless Brian was already wearing my V60 back here, and I already had him at a CPAP of 10. Okay, so if I already had him at a CPAP of 10, I have to match it when I intubate. Does that make sense? Okay, otherwise go less. We're going to start talking tomorrow about treating blood gases and how we go up or down the FiO2 versus CPAP scale. Whatever they need, we're going to get into that too. PEEP is used, so PEEP, CPAP, and EPAP are used to treat an intrapulmonary shunt when you've already proven the patient needs FiO2 of 60% or more. At that point, they're broken, they need more help. Okay? Now, when to change from volume to pressure control when you're already working on somebody on a vent. So they're already in volume control. I need to consider putting them in pressure under 3 unique circumstances, and this is for the boards all day. It actually crosses over into the real world too, okay? So when I have a patient who's approaching a peak pressure of 50 centimeters of water, and their plateau is approaching 30 centimeters of water, I need to think in my head, switch to pressure control. And that question that you see now on a quiz and a test is exactly from the board exam. Okay, where it had all this beautiful data, vitals are perfect, ABG was perfect, everything was great, except for the fact that you had a high peak and an ugly plateau. Okay? Those are 2 times we're going to go from volume control to pressure control. Another thing we haven't talked a lot about yet is right here. So when you have poor oxygenation, when you're using 60% FiO2 and you already have people on a lot of PEEP. So we've tried to correct our shunt. We're not getting anywhere. It's probably time to do volume control because you're at risk of damaging the lung. Does that make sense? Okay. So when this is happening, this is a problem. I need to actually switch them to pressure control. So 3 reasons. PIP of getting close to 50, plateau of getting close to 30, high FiO2 requirements when you already have a lot of CPAP. Does that make sense, guys? Okay. In fact, that is a question exactly like that on your next test. Huh?
Is this kind of more of like a board thing, or is this also something that's very standard in a hospital?
Both. Both. Definitely a board thing too.
Okay.
And you will see a question written just like that for the boards. But again, they were trying to think, how can I keep you safe? I have to ventilate you, but how do I keep you as safe as possible? Because we're going to talk, I think the next week or the week after, where we talk about everything that goes wrong because of mechanical ventilation. We do a lot of bad things to patients' bodies physiologically by putting pressure in their chest. So you fix the lungs, we keep your brain alive, keep your organs oxygenated, but we cause a crap ton of mischief. Okay. And one of the things we're going to try to avoid is by going to a pressure control mode. That would help. Pressure support by itself, so PSV as a mode, spontaneous mode of ventilation. Write that somewhere in big fat letters, spontaneous mode. This cannot be used on somebody who is heavily sedated and paralyzed. And again, that should make you go duck.
Because you can't separate.
Right, precisely. And I will give you an example of that. One of my colleagues used to work at AMG before all you all got there, and they had hired some RT from, I don't know, somewhere else, some other planet, I think.
Nebraska.
Huh?
Nebraska.
In Nebraska,
It's like
somewhere. Somewhere, and it wasn't that Nebraska girl, I know what you're talking about. But she went and put a lady who had come back from surgery, like they had to take her out of AMG. This is when they were across the street from Loveless. They had to take her to surgery, and they brought her back for whatever reason. She was totally out still, like the lady was completely out still. I think they sedated her for transport, and she just wasn't even doing anything. So she got back into the room, the therapist put her back on her vent. She was on PSV before, only now she was knocked out, and she walked away. Well, guess what? 5 minutes later, the lady coded, because she wasn't breathing the whole time. Yeah, that cost that girl her job. And I'm pretty sure it cost her license. So yes, PSV as a standalone mode, there is no set rate, cannot be used on people who are not spontaneously breathing, okay? Now, we love pressure support as part of other modes like SIMV because it can help overcome all of this awful mechanical dead space. You guys are not going to want to breathe through that circuit without some help. It's just too much effort, okay? Questions so far? This is all stuff we've covered, we're just taking it a little slower, okay? Now, peak flow settings, if you're able to physically set it as a value, some modes have it, some modes don't. Some vents have it, some vents don't. So, when Ms. Polly asks you on your mini clinic, if you have a peak flow, if you cannot find a physical value on the machine, you need to calculate it, okay? So we set the peak flow, if you have the option to set it, between 30 and 60 liters a minute, okay? As you guys demonstrated for yourselves yesterday, if you used a 60 liter a minute peak flow with the tidal volume that you appropriately picked, your eye time was real stupid, right? Like less than a half a second in most cases. That's not going to work. So we need to consider our peak flow. Peak flow, total flow, same thing on the vent, by the way. I need to consider that because if I'm not paying attention to where I set the peak flow, I could have a weird situation happening with eye time if I am not able to set the eye time. You noticed on the 980, you have an eye time setting, so I can dial in 1 second, okay? But I also can mess with how fast or slow it goes by using the rise, okay? Rise time will help fiddle with the flow a little bit. So we can adjust the flow once the patient's been placed on the vent to help straighten out their IDE, okay? If they're looking like their eye time is too short, their E time could be too long, they're gonna have asynchrony happening. You can even have some inversion if something's happening where the eye time's too long and the E time's too short. So all of these are related. And yes, Miss Kathy, that is why I made you learn all those awful formulas for eye time, E time, total cycle time, and ID. So you can understand the relationship why this happens. Now the shortcut to this is more flow equals a shorter eye time. I'm just getting there faster, okay? If I want a longer E time, I just decrease the flow. Longer E time, I decrease the flow. And this actually went all the way back to IPBB. If you guys remember me talking about this, when you played with that, the breath got to you quicker, didn't it? And I said, no one's going to care about IPBB except for the boards. You won't do it, but that is the fundamentals of ventilation, and here we are. Okay. If I increase my rate, well, then I have less total cycle time, don't I? If I have a rate of 15, what's my total cycle time? Yeah, if I go to 20, what happens to my total cycle time? Yeah, so I lost a second, right? So now I'm gonna have a rate of 20 going, I have a total cycle time of 3, so I lost a whole second in there somewhere. So I may have to adjust either my flow, my rise, or my I time to make my I to E make sense. Is that clear? Does that make sense to everybody? And the more you play with events, it's gonna, okay? So we like to have an IDE ratio of a 1 to 2 on purpose. You should exhale longer than you inhale so that we don't have air trapping. Okay? Every once in a while, old school, we used to use pressure control and do an inverse IDE on purpose. Not a nice way to breathe. Patients had to be paralyzed and drummed up quite a bit to tolerate it. By the way, when you guys get out to clinicals, I'm really curious to see, because we have one physician who likes to undrug all of our prone people, even though they're being prone still. COVID, super high settings, ridiculous peak, 100%, being prone twice a day, and he takes off other drugs. So I think he's a sadomasochistic troll. So that's a different problem. He's from a different country, and in his country, he is roaring, and we're all just supposed to listen. I'm like, y'all haven't met me? That's dumb. And he got thwarted in the ICU last week, and I'm waiting. Those nurses are about to eat him because he's doing really stupid crap. But old school, pressure control, inverse ID, they had to be paralyzed because we were forcing them to breathe in longer than we were letting them exhale, and there was significant air trapping happening. The purpose was to recruit a VLI, right? But it's not a nice way to live. It's not a nice way to breathe. So the following will affect the IDE ratio and volume control ventilation. The tidal volume that you set, because remember, the machine has to think, I need to get this much volume into Leah this many times a minute. How do I do it? Okay. Flow, if you can change the flow, you can have some power over that, and also the rate. So all of these things are related as to how the IDE ratio is going to be. Now, if you watch the vent, and you've seen me play with it where I was breathing for it, and when you get to rotation, this will make more sense. But you can have somebody who's breathing 25 in a 3-minute time frame, and then goes down to 10, and then to 20, and then to 15. They could be all over the place. So that IDE is going to continuously change. Okay, so every exhale breath, the IDE could be different. It could be calculated different. Okay, so you're just going to kind of watch for an average, and if somebody's breathing all wonky, you need to find out why. There's a reason they're not tolerating it. Okay, any questions? All right, so sensitivity. Sensitivity is how easy it is for the patient to cycle the breath on. We want to keep it right around 2. There is a pressure and a flow trigger. Okay? And sometimes it's just a matter of preference with playing with it to see which one they like. Hello, Miss Kelly. How are you doing?
I'm fine. I think I left evidence of the vaccination in here somewhere.
Oh, you in the right book?
Bunch of other papers?
I don't know. I handed some papers to you when you left.
Yeah. There's more. I'm sorry.
No worries.
It's not here. Okay. Y'all didn't find other papers, right? Okay. So, here.
My junk.
Your stuff, yeah.
At Tesco. I'll do.
And you know?
Is it bad? I've never done it yet.
Huh?
I've never had to be tested yet.
Oh, they made me do it myself.
Oh, yeah?
Yeah, and I know how to shove something down my nose.
Well, yeah. Well, because in the beginning they were doing it to you and like picking out stuff out of the backside of your skull. Like, wow. And then you'd watch people do it themselves and they're like, I'm just going to wipe this booger right here. Well, that's not going to say anything.
No, that's not gonna say a thing, so, no, they got it with me and they said, here, do this, and I said, I know how to do it.
Right.
How far back do you want me to go? Because anytime somebody calls me honey,
Oh. Like, would you like me to scratch the back of my skull with this? Because I can. Yeah.
yeah, it's like, I'll do this. Like, and they break it off. You know, it was easy to get there.
Yeah.
I know
You
you
stay
all
in your car?
been through it. Yeah.
Yeah, I was thinking.
Never even got out, it was just like, a little flashy thing here, see this, and we're done. I don't think I've been exposed. Here's the deal. If you have cough, you should probably get tested, right? Because I have grandchildren.
Yeah. We were talking about that student that we had because I had her, you
Yes,
didn't.
I didn't,
So-
but I helped you in labs.
That's true.
Yeah.
That's true.
So, and since I have a little
something.
A little something, something, I'm gonna get,
But that's what I was telling them, because you were fine, Monday you were fine, nothing came
Yeah.
out, and like Tuesday was there.
yeah.
So.
But then again, my grandson drank out of my coat
Ah.
on Saturday.
Oh, yeah.
or Sunday. You know that happened. That's what,
Ah.
it's 4-year-old boogies.
They still get COVID.
And they
Yeah.
are little petri
Well, Leah was
dishes.
telling me that her mother-in-law has it too, and didn't even test, she has not a sign or symptom, she tested positive immediately. Her coworker got it, she went got
Oh, okay.
tested, did a home test, it was positive, went and got the real test, it was positive, she feels fine. It's only day 2 though.
Yeah.
I don't know, I don't even wanna know, I just wanna lay around not waiting for it to land on me, like, I don't wanna be like day 3, day 4, day 5, like, am I dying today with that?
Nope, I'm gonna test,
Yeah.
because, you know, I wanna be prepared. I do not have time to fool around.
No. Well, and I was just saying that if I get sick on my break, I'm gonna lose my mind. I'm gonna actually
Yeah.
taking somebody out with me,
Yeah.
so. I'm gonna be on
Exactly.
the roof, screaming profanities at people, why don't you wear your mask? Get your
And
shots, you stupid
Clovis, oh my
civilians."
God.
Oh, down south, yeah.
Oh my God.
Yeah.
Nobody wears a mask.
Yeah, Alan McGuire was the same way. Like I said, my sister-in-law and brother-in-law came from Colorado, both COVID positive, mind you. Licking horses' butts and doing whatever they do with the ivermectin. Drove clear down to Alamo with her mom, who is a stage 4 cancer patient at the moment, who also did ivermectin because it saved everybody in Alamo. I'm like, man, whoever came up with the horse industry is like having a big time. But they're all fine. They're all fine. They're so big now. That's like, I told them, I said, I don't care if you do witchcraft free and you like pray to the rocks. I don't really care what you do. You can lick horses' butts, do whatever makes you happy. Just do the stuff that actually works. Like, get your shot.
And then do the dance.
And then do the dance and pray to the sun gods and whatever it is you believe in. I don't have a problem with
I
that.
think though, like with her too, though, 'cause she's fully vaccinated and she got a booster,
Yeah.
which
But-
is kind of crazy that she got
Well,
it.
you can still have it living up your
But
nose.
I think that's why maybe that's why she doesn't know.
It's
She
been a
has
long
not
joke that
said
if you were
that
to
she
swab me,
has-
unless you worked in the hospital for length of time, we all have MRSA in our nose, I promise you that. I will
Sure.
never let anybody look, because I don't wanna be isolated till the end of time, but anybody who's worked in a hospital for more than 5 minutes, you
Oh,
have
yeah.
MRSA living in your nose. So,
Cricket showed me the Loveless statistics, and it's like, you know, that's.
Oh, yeah, it's hideous.
Yeah,
It's
it's
so
like, you know, a bunch of people with the symptoms,
148
with
COVID.
COVID, and there's like 5 of them who had the shots. And then of the people on ventilators, there's,
38.
which are all COVID, none of them had a shot. And the ones that died, never had a shot. So it's like, okay, you know, yeah, it's like 4 to 6 of them, yeah, you'll get sick maybe, but you won't die. You may be in the hospital, but it's a high likelihood you're not gonna, it's not gonna.
Yeah, I just had it
die.
yesterday too, one of my husband's cousin and his whole family had it too. But their little boy has something called Addison's disease, I don't know if you've ever heard of that.
It's a kidney thing, right?
There's a lot to it,
Didn't
but.
John F. Kennedy have that?
Mhm. But the primary scary part is that he takes high dose steroids all the time to keep it in check. So he's already on that and now he's really sick. So he was actually the one who got H1N1 too. that year.
Oh, yeah, H1N1's another killer.
Sound viruses. I told her, I said, we all need to go home right now and just bubble up because I don't wanna be around these sick people. Can we just, cause you know, doctor was leaving Tuesday. I say we just shut it all down. We go home for an extra week. And
Honestly,
we stay in our
no,
bubbles.
I got things to do. I got things to do
I know.
with everybody.
Oh, they were having trouble getting to their modules for press.
Okay,
Again.
I emailed you
And
that.
how many do we have to do? 'Cause it's
There's-
showing that we have like 22 to do.
That's
That's it.
Yeah.
Okay. I thought it was just like a few.
better than there used to be.
It used to be 36.
Yeah.
Well, I thought that's what we like originally did.
Yeah,
for
but
the
these,
first
some of
ones.
these are, you have to do them manually, and that's what they're doing.
So that's what
I'm
confused
sorry.
me though, because we just did them like earlier this year.
They don't care about that. The calendar starts again in a minute. So they don't care about that. It's Presbyterian. Now, if you happen to work at Presbyterian, they're gonna forgive you on some of your modules. So I told them that they'll let you know, and.
It's not Ashley, it's Alexa. Yeah, Alexa.
Alexa, she's not here.
Yeah, okay, and then you, so you may end up not paying the highest price. However, if you have a hard time logging in, let me know, I'll email her, she'll tell me what your login name and password is, and then give me the number of the place you call so that they can help you.
It's a mess.
93,
And
68.
halfway
I
through,
logged
you'll be
into
locked
it.
out of it.
I
It's
logged
really good.
into it, like, I don't know, when they first sent them to me, I should have like 20 something to do, and I'm like, what the heck? And then I logged out, and then when I tried to get back in, it was probably like 2 weeks ago or.
Is it letting you in?
It wouldn't let me in.
Okay, so here's the deal.
So,
The clinical coordinator goes on vacation, like, and the person who is taking care of things for her is not pleasant.
okay.
So she wants it all done before she goes on vacation,
Before she goes.
which is why you have a deadline from me. She is going to check on this on Friday.
Okay. I'll
So-
get them done before Friday.
Good.
I'll
Call the helpline.
I've had to call the helpline
Yeah.
before. So
Yeah, they're somewhat helpful.
They're nice.
Yeah, they're nice. So, and, you know, just get it done. So it's not you.
No.
Okay, it's not you, it's you, it's you. And then she, okay, so I got Alexa on there, so who knows what they wanna make her do.
I don't know. It's so done though, and like half the time they close you out halfway through it, and you can't cheat and skip it to the end either, because they ask you questions as you go, so you have to watch every stupid minute.
And if you get the eternal spinning wheel, call the helpline, because they might have to reset that module.
That happens to me.
Yeah.
And then they.
And
do,
it
like, the
always
wrong
happens
ones.
to at least one student every cohort.
Yeah.
So I
Yeah,
already.
did we say what was better? Is it Chrome or,
They actually say what it is on there.
no, but one was better, like if you get
I
the
think
single
it's
wheel of death, you're
Internet
supposed to
Explorer.
flip it,
Yeah.
yeah.
They do say what it is on the instructions,
Okay.
like maybe you could read it.
I don't really remember that
Oh.
one, but I'm sure it's good.
Hey, sure, it was there, it's a thing.
Yeah.
I just don't want to do it. I'm sorry,
Well-
I'm gonna just be honest.
I don't like doing it either, you know what I don't like doing? I don't like having an intermediary between me checking up on you guys.
Yeah.
I'm not able to see them, and it infuriates me. I should be able, we're missing somebody.
Here,
Alexa.
Alexa.
Okay.
Alexa.
It infuriates me that I cannot personally check up on you. And it's like, dang, I could nag you a lot better if I was checking up on you, but she has to. So, it's okay. So Press does have some, I have to tell you, I worked there 24 years and I loved what I did. Loved pediatrics, loved PICU, loved it a lot. There are other things about Press that I don't care about, but you know what? Their paperwork, oh my God. However, I loved the PICU.
Do you
Still
feel like
remember.
though all their paperwork and all their loops and all their things, it creates a little bit more accountability
Well,
in your.
they have a
among your
closed loop system.
People.
I almost said something completely inappropriate.
La 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 la. La la la.
I was going to say, so I'm gonna say it anyway, that they're halfway up your butt on a good day, so it really doesn't matter if you're closed loop or not, they're going to find you. They're going to
Yes,
find you.
yeah. They probably still have all my documentation from my assignment sheets from like 1994.
You had to turn them in,
Yeah.
like your
They-
brain,
and
you
they
work on it,
saved
that
them.
you had to turn them in.
They were in files.
Yeah.
Yeah.
And when I got hired there, the first day I oriented, they sat me down with 6 binders that were this fat
They
and told me to
probably
read them.
Even now, when we still do
They
the.
take them from you?
sheets, we have to-
I was like, can't you just
And
write
then they
to me
file
like
them.
where stuff is? Like, I don't care about the policies,
Yeah.
and they made me read them all. I'm like, two
They
pages,
probably still have
2 cups
mine.
of coffee, I'm like, I can't. But I did 2 years over there, and you learned a lot. Press, like I said, excellent for PQ and NICU. I didn't really care for the rest of it.
I liked all intensive care there.
Oh, yeah.
As long as it's.
No, the
12
nurses up in the
nurses.
ICU were horrible at the time. We're going back to 94 though, it was a long time ago.
Yeah. Well, you know, I have to say that they took really good care of my husband when he was in the CCU. They were really good. But I had nurses that knew me. And travelers of all things, they were really good. I was really like, wow, this is, no, I'm not staying here. Why not? This is, New Mexico is not very entertaining.
You're
Nothing
right.
to do there. Well,
You don't like dirt? Really? Sorry.
You don't like dirt and mountains? Jeez.
There's
You
mountains
know,
and
you
trash
really-
and homeless people? Sorry.
Anyway, I ratted out the homeless encampment up on Quincy yesterday.
So, I wish I knew you did that because the other thing I wanna rat out, I was driving on the off-ramp to Fair to San Mateo and that entire wall is full of trash. It's been that way for a month, not a single trash person has come to look at it or to pick it up, it's just covered in trash.
Okay.
It's really annoying.
Well,
I don't know who to yell at, but it's really
I
nice.
don't either. I usually call 311 and ask them who to yell at.
Good, that's lovely.
I do. Oh, they're on, like, you don't even need speed dial.
Cause there's a nice homeless encampment right across the street up here about 2 blocks too.
I don't have a hair tie. I had some car trouble, and my hair tie
Oh, no, it's a day?
is,
Did you put your hair tie in your car engine, is that what happened to it?
No, I put it on the gear
It went-
shifter.
Yeah.
Oh,
They're all
it's fine.
gone.
I guess I'm gonna have to go to the Dollar Tree and buy more of them. I used to keep them here, I know. That was my sign. That was my sign. All right, so here's the deal. I gotta go. Do y'all need anything? I'm hopefully gonna finalize the, schedule. I was actually looking for it. I was gonna forward it to you, but I can't find it on my computer. I don't know what happened to it. I did find Kathy's grandmother's wedding ring.
I know, check this out. So here's what's funny, so,
I know.
so my husband's grandmother, so I'm sorry, I'll have to shorten that. So my husband's stepfather, major ass, grandparents, super nice people, always been nice to us. The grandmother passed last year and gave me this piece of turquoise that I'm always getting comments on, because her grandpa actually mined it out of Battle Gulch, Nevada. But she also, in a bunch of useless jewelry, had this one little gold pinky ring. And I loved it, I wore it everywhere, and then one day it just was gone, and I thought it was at the house, I remember taking it off on the counter, and I never saw it again. That was last year. This morning I picked this up, and I'm holding onto it, I'm kind of thinking of her, and Polly comes in this morning, she goes, look, I go, oh, that is this ring, I've been looking for it for a year. It was in a pediatric box, in there.
It was in a box of pediatric stuff. It was right at the bottom. I was digging through like this, and I saw that little ring, and I thought, that doesn't look like a fake piece of crap. So I picked it up and went, that looks pretty good. Put it on my pinky finger, and I said,
So
look
I
at
was
that.
surprised I got it, because when my father-in-law realized it was real gold, he probably would have kept it, but he gave it to me. There you go. It's a little bit big, so I have to be careful. But yeah, I was looking all over there for a whole year. In fact, I was blaming my mom for taking it, in fact, because that kind of stuff has happened.
Oh.
Yeah, because she didn't have it.
So I have one question.
Okay.
Is Loveless gonna be our third location? Or-
Okay, so here's the deal. I'm dividing you into 2 groups. Okay? Mondays and Fridays. So we have one person on Fridays at UNM, one person on Mondays at Loveless, one person on Mondays at Press, and one person on Fridays at Rust. So it's gonna be UNM and Loveless and Press and Rust. And about halfway through, you're gonna go like this. And then Wednesdays, it's gonna be fun. Wednesdays are special. You know, Wednesdays are special, and actually working on that right now. HME Specialists, which is a home care company. Cath Lab at Cath Lab at Press, Cath Lab at UNM, Dr. Dorf's office, Espanola PFT. So you know how when you go to Espanola, you go to the right to the respiratory department? This time you go forward and to the left, which is the PFT people. It's Frank and Marie. So I'm gonna go there. And there might be one other place. I haven't found it out. So you may be scheduled for a day off. We'll see how it goes. 2 go to Cath Lab and 2 go to the other Cath Lab at a time. So
when we go to like press and stuff, we're going
What?
we're going individually, or
Where?
we're going in groups of 2s?
Yep, everything except for the Cath Lab is 1 person at a time.
Oh, cool.
Yeah,
That's awesome.
it is. You get to kind of cruise in, and everybody's desperate for help, so they're like, they ought to be like this. Hey, hey, how can we help you? No, you never know. You know how the difference between the clinical sites last time? There's also differences between these clinical sites on Wednesdays as well, and any clinical site. UNM is a 6 a.m. to 2 p.m. shift. Everything else is 7.
Issue or something else like that, okay? Now, our inflation hold is also known as our plateau hold. We've done this a whole bunch of times. Plateau pressure references alveolar pressure. We don't want it to be really high. Remember, when it's creeping up on 30, that's not good. Now, If you're going to leave your plateau pause built into the system, like on the servo for volume ventilation, it lives there at a 0.4 seconds, okay? The reason for it is to help recruit alveoli and to increase oxygenation. That's the purpose. And for people out of post-op, that's a great thing to do. But the second somebody starts to wake up, they're not going to appreciate you doing that anymore. So you need to take it away. The disadvantage of a permanent hold is it lengthens eye time, which actually increases airway resistance, which is PAW, or you'll see it as RAW. The more pressure we put in the chest, and I've said this 3 times today so far, will have an adverse effect on somebody's hemodynamics, okay? Cardiac output. Okay.
Okay, so I'm confused, so that PAW is the airway resistance?
Pressure in the airway.
It's not the mean airway, because I know that's.
So mean airway pressure, so PAW, look, I don't want to change that actually. I don't think this came out of Egan's right. Fix that. Go back a slide, guys. Right here, where it says this, where it says PAW, fix that to RAW, resistance of airway. I think that's a typo. I think that came up last class too out of Egan's, and I'm like, that's a way to extend the exhalation time. You're just making the exhalation time longer. It's dumb. We don't do it anymore. I wanted to pull the slide, but Dr. O said that they actually still every once in a while ask you a question about that in those terms, and they're not the same as an expiratory cost.
So would you set something on that?
You
Or
would
is it
set
just like-
something,
okay.
you would set something, so when the patient would go to exhale, you would set an expiratory retard. So instead of them being able just to exhale, a resistor valve would close inside the vent, so you're actually having to exhale like against pursed lips. Like if you go, and you feel that back pressure, we're forcing the patient to do it with the vent.
So it's like pep therapy?
Kinda, but not in a pleasant, beneficial way, just as in a you hate life and you can't exhale kind of way. Okay? I've never used that. I've never played with an event that had it, so I don't know. But the board still talk about IPVD, so you never know. You never know. All right, so again, just to review, in setting up the ventilator, you know you obviously have to have a nice clean vent. Somebody has most likely self-tested it already. It's ready to go. Somewhere on here will be a sticker that said it passed its calibration and the date it did that and who did it, because if something stupid, you need to have somebody to blame. So if they left a filter off, if they left something disconnected, and you go to set it up, especially because we're using a lot of people who are students right now, and they may not be getting properly trained. So if they're putting stuff together that's not right, we just need